Week 6, End-of-Life Care. The readings for this week are chapters 10, 11, 16, 57, 58, and 59 in your textbook. And in Perry and Potter, there's chapter 36. Please take a look at box 22-2 on page 288. Also look at page 293. And in the concepts book, please take a look at chapters 11, 33, 48, and 49. After completing the assigned readings, attending class meeting, study and review, you should be able to answer the following, or understand the following. Describe the prevalence, incidence, survival, and mortality rates of cancer in the United States. Describe the processes involved in the biology of cancer. Differentiate the 3 phases of cancer development. Describe the role of the immune system as it relates to cancer. Explain the use of surgery, chemotherapy, radiation therapy, and biologic and targeted therapies in the treatment of cancer. Identify the classifications of chemotherapy agents and methods of administration. Identify the various complications associated with advanced cancer. And finally, describe the psychological support interventions for cancer patients, cancer survivors, and their caregivers. Slide 1. Cancer is a condition in which cell growth and reproduction is uncontrolled and unregulated. The overall rate of cancer has been declining since the 90s, along with the mortality rate. However, there has been a growth in the rates of certain cancers, leukemia, liver, and skin cancers. Cancer incidence overall is higher in men than in women. Although the mortality rates from all cancers combined are on the decline, cancer is still the second most common cause of death in the United States. Heart disease is the most common. However, in people less than 85 years of age, cancer is the leading cause of death. Annually, about 580,350 Americans are expected to die as a result of cancer, which is more than 1,500 people per day. Medical advances have led to longer survival for those with cancer. More than 13.7 million Americans are alive today who have a history of cancer. The overall survival rate is now 68%, 19% increase over the last 30 years. This statistic represents Americans living with cancer, including those who are disease-free, in remission, or undergoing treatment. Slide 2. Gender differences for cancer. First, we'll go with men. More men than women die from cancer-related deaths each year. The mortality rate from lung cancer is higher in men than in women. Esophageal cancer is more prevalent in men than in women. Cancer with the highest incidence among men is prostate cancer. Men are more likely to develop liver cancer than women. Head and neck cancer occurs more frequently in men than in women. Bladder cancer is at least 3 times more common in men than in women. For women, cancer with the highest death rate among women is lung cancer. Non-smoking women are at greater risk than non-smoking men of developing lung cancer. The cancer with the highest incidence among women is breast cancer. Thyroid cancer is more prevalent in women than in men. And women are less likely to have colon cancer screenings than men. Slide 3. The normal cell life cycle. The normal generation time for cells that are continually replaced, such as epithelial and epidermal cells, is from the mitosis phase to mitosis phase. After initial mitosis, the cell divides, moves into the resting phase, where the cells actually perform their normal biological functions. At some biologically determined point in the cell's life, it prepares to divide again and re-enters the mitosis phase. The original cell that was triggered to divide then dies. So in normal circumstances, the number of cells remains stable. One is created, one dies. Cancer cells are different in that the parent cell lives on, and the total count of cells increases with each iteration of the mitotic cycle. Slides 4 and 5. Cancer develops over 3 broad stages: initiation, promotion, and progression. Initiation is due to a change in a cell's gene, a mutation. which is a change in the cell's DNA. There are two primary sources of genetic change. Inherited, a parent passes to the child a mutated gene, or acquired. That is, some sort of genetic damage due to an individual's exposure to a mutagenic agent. About 5% of all cancers are inherited. The remainder are due to cells with damaged DNA that are able to replicate and pass on the altered DNA to their daughter cells. Carcinogens are typically environmental and range from chemical and radiation exposure to other biological agents such as viruses. For example, the human papillomavirus, HPV, is one such virus. Following initiation, the next stage is promotion. This is where the population of altered cells begins to grow and proliferate. At this stage, the cancer is usually reversible by removing or reversing the promoting agent, such as dietary fat, obesity, smoking, and alcohol. The final stage, if promotion is not reversed, is progression. This is where the tumor grows more quickly and becomes increasingly invasive and then spreads or metastasizes to other sites of the body and other tissues. Slide 6. The main sites of metastases: the brain and cerebral spinal fluid, lungs, liver, adrenal glands, and bone. Slide 7. Tumor progression. Angiogenesis. Angiogenesis is the development of a blood supply to the tumor. Without blood, the tumor would stop growing once it became too large for nutrients and waste products to diffuse through the tissue. Following angiogenesis, tumor cells detach and invade the circulatory system, landing in organs on a random basis. There they adhere to the vessel wall, extravasate from the vessel and into the surrounding tissue, and then they begin to proliferate, leading to a new tumor site or metastases. Slide 8. The immune system can often identify tumor cells just as it would foreign cells. The tumor cells can have tumor-associated antigens, which will identify them as an invader, and which will stimulate the immune system to destroy them. Cytotoxic T cells, natural killer cells, macrophages, and beta cells are all capable of destroying tumor cells. While T cells can directly kill the aberrant cells, they play a more important role by releasing cytokines, such as interferon, that stimulate the other immune cells. The natural killer cells are stimulated by the release of interferon and interleukin. Monocytes and macrophages are also activated by interferon, which will lyse the tumor cells. And additionally, macrophages release tumor necrosis factor, TNF. The monocytes and macrophages are nonspecific. Conversely, the beta cells can produce specific antibodies which bind to the tumor cells. Slide 9. The process by which cancer cells evade the immune system is termed immunologic escape. Theorized mechanisms by which cancer cells can escape the immunologic surveillance include 1. Suppression of the factors that stimulate T cells to react to the cancer cells. 2. Weak surface antigens allowing cancer cells to sneak through the immunologic surveillance. 3. The development of tolerance of the immune system to some tumor antigens. 4. Suppression of the immune response by products secreted by cancer cells. 5. The induction of suppressor T cells by the tumor. And 6. Blocking antibodies that bind TAAs, thus prevent their recognition by T cells. Slide 10. Some types of cancer cells are capable of producing oncofetal antibodies, which block the tumor-associated antigens from the cytotoxic T cells. Slide 11. Histological classification. Grade 1. Cells differ slightly from normal cells, mild dysplasia, and are well differentiated, low grade. Grade 2. Cells are more abnormal, moderate dysplasia, and moderately differentiated intermediate grade. Grade 3. Cells are very abnormal. This is a severe dysplasia and poorly differentiated, high grade. Grade 4. Cells are immature and primitive, anaplasia, and undifferentiated. The cell of origin is difficult to determine, also high grade. Grade 10. The grade cannot be assessed. Slide 12, staging. Stage 0, cancer in situ. Stage 1, tumor limited to the tissue of origin. It's a localized tumor growth. Stage 2, limited local spread. Stage 3, extensive local and regional spread. Stage 4, metastases. Slide 13. The TNM classification system. Primary tumor, T. So T0 is no evidence of primary tumor, TIS is a carcinoma in situ. T1 through 4 is ascending degrees of increase in tumor size and involvement. TX, the tumor cannot be measured or found. Regional lymph nodes, N. N0, no evidence of disease in lymph nodes. N1 through 4, ascending degrees of nodal involvement. NX, regional lymph nodes unable to be assessed clinically. Distant metastases, M. M0, no evidence of distant metastases. M1 through 4, ascending degrees of metastatic involvement, including distant nodes. MX cannot be determined. And note, for examples of TNM classification system applied to diseases, please see figures 3114. Actually, I need to double check those. Ignore the figure references. They may be from a prior text. Slide 14. American Cancer Society's CAUTION acronym. C is a change in bowel or bladder habits. A sore that does not heal. U, unusual bleeding or discharge from any body orifice. T, thickening or a lump in the breast or elsewhere. I, indigestion or difficulty in swallowing. O, obvious change in a wart or mole. N, nagging cough or hoarseness. Slide 15. The treatment goals start with cure if possible. If no cure is available, the next treatment goal is control. And finally, if control is not an option, palliation. Slide 16. Surgery plays multiple roles, which range from diagnosis, a biopsy, staging, cure and/or control, prevention by removing non-vital organs to prevent spread, supportive care, rehab, reconstructive or plastic surgery, and palliative care, tumor debulking, pain relief. Slide 17. Similarly, chemotherapy's goals also range from cure to palliation. Slide 18. Radiation therapy is one of the oldest methods employed to treat cancer. The type of radiation used to treat cancers is ionizing radiation. It's a form of high-energy radiation that can shatter molecules, and in so doing damages the DNA of cells, leading to cell death. The ability to focus a radioactive beam on a very small target has significantly improved over the decades, leading to a reduction in the collateral damage and cell death to healthy tissue. Slide 20. Cancer patients need a spectrum of psychological support. They need their medical and support staff to be available during difficult times. They need for them to exhibit a caring attitude, to listen actively to fears and concerns, and to help provide relief from distressing symptoms. Staff should provide essential information regarding cancer and cancer care that is accurate and establishes realistic expectations about what the patient will experience. A relationship needs to be maintained based on trust and confidence. Be open, honest, and caring in the approach. Use of touch to exhibit caring. A squeeze of the hand or hug may at times be more effective than words. Patient assistance in setting realistic, reachable, short-term and long-term goals. Assistance for the patient in maintaining the usual lifestyle patterns. Finally, help with maintaining hope, which is the key effective cancer care. Hope varies depending on the patient's status. Hope that the symptoms are not serious, hope that this treatment is curative, hope for independence, hope for pain relief, hope for a longer life, hope to achieve meaningful goals, or hope for a peaceful death. Hope provides control over what is occurring and is the basis of a positive attitude towards cancer and cancer care. Slide 19. Cancer and the associated treatments can lead to a broad range of complications. The complications can be themselves life-threatening, such as cardiac tamponade, carotid artery rupture, or even hypercalcemia. Or they may be more chronic in nature, affecting ADLs and the quality of life, such as chronic pain and malnutrition. Slide 21, end-of-life care. As you all probably realize, and may have even had to deal with, there comes a point where a patient can no longer expect medical science to cure or even extend life. There is a challenging and important role for the nurse in the performance of end-of-life care. Slide 22. End-of-life care is covered under 3 broad categories, and you'll likely hear various definitions of these terms depending on where you practice. The differences are both philosophical and geographic. In general, in California, palliative care is focused on reducing the severity of symptoms rather than any further attempt to cure. End-of-life care is often used to refer to situations where death is imminent, but the definition of imminent varies by community and culture. Hospice and/or comfort care typically refer to the level of care that is focused entirely on pain management and assisting both the patient and loved ones with the impending transition from life to death. Slide 23. In many care communities, palliative care encompasses both end-of-life and hospice care. Slide 24. If you're practicing in the hospital, you may find yourself caring for a post-surgical patient who underwent an operation to reduce the size of a tumor, remove cancerous tissue or organs to slow the progression or to manage pain. Slide 25. Many benefit from not spending their last days or hours in the hospital. In particular, hospitals are challenged to effectively care for those suffering from cancer-related dementias, disorientation, or delirium. However, in the home situation, those same challenges exist, and patients who become violent, totally disoriented, and demented can also really challenge the families. Slide 26. In most care communities, the agreement by a patient to enter hospice care entails an agreement and acceptance that life-saving efforts will not be made as the end approaches. However, these contracts are not binding. If a patient or family member chooses to call 911, they will be treated accordingly. Slide 27. Hospice home care incorporates a challenging level of nursing care, assessment, and communication with patients, loved ones, and other medical professionals. It's a role that is demanding. There's 24-hour call and emotionally challenging. Slide 28. Finally, as nurses, we may be exposed to situations which are so emotionally challenging that we need help to sort out our own feelings, heal, and stay healthy. Nursing is a very demanding vocation, both physically as well as emotionally. If we don't have the tools and support needed for our well-being, we may well find unhealthy and dangerous ways to deal with the stresses.